So today I'll be going over OPLL, its challenges and surgical nuances, and delve into the recent literature, looking at the most recent publications on the subject matter. I became interested in it over the past year, just dealing with challenging cases in patients with OPLL. One I remember vividly was a lady that came in with very focal OPLL that was with significant dural ossification that we subsequently had like a CSF leak on. And anyway, just got me thinking about management strategies on these patients, what the best operative approach was, because and it was something I didn't know a lot about. So I wanted to delve into a little bit more to understand the pathology and surgical nuances. Let's see if I can go to the next slide. Okay, here we go. So just an overview of what I'll be discussing today. So briefly go over the history and epidemiology. We'll then delve into the pathophys and histopathology, and then start wrapping up the presentation with in terms of talking about the patient's clinical presentation, diagnostic imaging, and then finally the natural history of the disease, whether conservative management is ever warranted, and finally the surgical management, which I think is the most interesting, and the subtleties of it. So as we all know, OPLL is a rare condition. It can, we often think about it leading to cervical myelopathy, but it's important to know that it can also lead to thoracic myelopathy, although this is much more rare. As we all know, it may have an increased prevalence in certain races and ethnicities. And this is due in large part due to the increased number of publications that have been done in East Asia, specifically Japan. While the etiology remains unknown, there have been associations with specific genetic loci that have been reported. In terms of the historical background, OPLL was first reported in 1838. It's attributed to this gentleman on the far right. You see an image of Charles Ashton Key. He was in Guy's Hospital in London, and it was identified as a cause of paraplegia. It wasn't until 1960 where Tsukimoto's autopsy report in Japan was widely cited as the first to really recognize OPLL as a distinct pathological entity. Some surgeons, anatomists in the mid 1900s had included reports of possibly discussing OPLL, but they may have been also describing dish or ankylosing spondylitis, which is something they were confusing OPLL with at the time. And then finally, in 1975, the Japanese government formed a study group in response to this autopsy report that was discovered and noticing increased incidence of this disease in their patients in Japan. And they launched an investigation committee on the spinal ligaments, they called. And this subsequently led to numerous studies, published reports. So in terms of the epidemiology, early on, when we didn't know much about this disease, and specifically in the early 60s, 70s, 80s, OPLL was considered a Japanese disease. And this is due to a greater volume of reports and what was thought to be greater incidence at the time, specifically in Japan. In terms of prevalence rates that have been reported there, they've ranged, approximately to 4%, with a recent CT study showing an OPLL incidence of 8.3% in men, 4.3% in women in Japan. However, looking at our own country, this was an interesting study that was done in San Francisco in 2015, looking at differences in incidence rates amongst the population there. And you can see, while in Asian Americans, there's an increased incidence of 4.8%. You got to remember that it can also happen in other groups, whether it be Caucasian Americans, they reported an incidence of 1.3%, Hispanic Americans, African Americans. So it's not exclusively a disease to East Asians or Japanese that we initially had thought early on when we were first researching this pathology. In terms of the incidence in the general population, it's thought to occur more frequently in patients who are older, 50 years of age, because that's typically when they present. And for cervical OPLL, the male to female ratio is approximately 2 to 1, and for thoracic OPLL, the ratio is closer to 1 to 1 with a slight female preponderance. Excuse me. Now, briefly, just to discuss the anatomy of the posterior longitudinal ligament. So it extends from the tectoral membrane, here highlighted in orange, and it extends all the way down to the sacrum. as you can see now highlighted in like a light pink color. Um, it consists of both deep and superficial fibers. The superficial fibers typically span several receiver levels, whereas the deep fibers are typically much shorter and they converge on the intervertebral disc. In terms of a more nuanced understanding of the PLL, it's important to remember that it functions primarily to limit flexion, and its normal thickness is typically only 1 to 2 millimeters. And here you can see a nice anatomical diagram showing the PLL. These are the superficial fibers running across multiple vertebral levels, and then you have again have deep fibers that run in between the intervertebral discs themselves. In terms of the pathophysiology, ossification is often thought to be the most common pathological process involving the PLL. However, it's important to think about OPLL as kind of a continuum that can oftentimes start with hypertrophy of the ligament itself, that then over time reshapes and can lead to intermembranous ossification of this initial hypertrophy, and then lamellar bone can start forming. Some authors have identified OPLL as an enthesopathy. This is something I didn't really know the definition of, so I went ahead and did some research on the topic. So for an enthesopathy, so breaking that word down, these are bony insertion sites of tendons and ligaments. So an enthesopathy would be any pathology that affects these bony insertion sites. Other diseases that have been grouped into enthesopathies, including OPLL, are things that that early on we were confusing OPLL for. So things like dish, ossification of the ligamentum flavum, spondyloarthropathies, and gout are just a few examples. So in terms of the histologic changes that happen in OPLL, again, it still remains poorly understood, but it's first thought that it's believed to first begin as hypertrophy of the ligament, and then endochondral ossification then ensues, and then it's thought that subsequent expression of BMPs within the PLL actually promotes further growth, and then forming lamellar bone. This is just an interesting example of just isolated hypertrophy of the PLL. You can see it on the MRI. It's results in severe cord compression, cord signal change. You can see it on the axial MRI as well. On the CT scan, however, we don't see any true ossification as of yet. Which is just interesting to see. Typically, because when we see patients, it's at that point, that ligament is ossified. Other associated factors that have been linked to the development of formation of OPLL, obviously the genetic associations that we talked about, like BMP and BMP receptors. There are also several collagen genes that have been associated with it, as well as like the TGF beta family. Some interesting non-genetic associations, so things like increasing age, which seems somewhat obvious, but then obesity and diabetes has also been closely linked to the progression and development of OPLL. So in terms of the pathological changes you see in the spinal cord as a result of compression of the cord from OPLL, the first thing to learn is that gray matter damage actually happens much more so than white matter damage. There is diffuse demyelination, axonal loss that are especially seen in the posterior lateral aspects of the cord, but the gray matter is actually much more severely damaged. Over a patient's lifespan, more so than the white matter. And also, interestingly enough, there are two different types of cross-sectional shape of the compressed cord that you can see in patients with OPLL that have been identified. So one is this boomerang type formation that can develop, which you can see on this right image that's in black and white. So in the boomerang form, you see loss of gray matter, but you have preservation of the long tracts. And in this more triangular shape, you see more diffuse degeneration of the gray matter, as well as some of the white matter, including damage to the corticospinal tracts and even some dorsal column involvement as well. And again, these changes primarily happen in the gray matter. And typically what happens is the anterior horns are moderately flattened, and then you see a loss of nerve cells and proliferation of glial cells. And the actual spinal cord damage itself has been classified into 4 stages, ranging from stage 0 to stage 3. Stage 1 being mild compression, and then stage 2 and 3 starting to see neuronal loss, and then intrinsic cystic necrosis. And it's typically thought that surgery should be offered at stage 1, as stage 2 and 3 are considered irreversible injury to the cord. And obviously, there's some changes that happen in the white matter as well. Typically, what you'll see is myelin destruction, loss of axons, and this and status spongiosis, which I've highlighted here, which you can see on this image on the right. And now I want to briefly now delve into clinical manifestations of OPLL. So again, symptomatic patients are typically older, greater than 50. Over 40% of the patients that you'll see for evaluation will have some signs or symptoms of myelopathy typically. And the likelihood of them progressing to symptomatic myelopathy is related to typically their initial neurological status when they first see you. This was an interesting study. This was a nationwide survey in Japan, looking at all the patients that they had been seeing in clinic with OPLL and their presentation in terms of their initial symptoms. So overwhelmingly, 74% of the patients presented with either pain or numbness in the extremities, and then neck or nuchal pain, changes in reflexes in the lower extremities and upper extremities were the other more frequently presented signs that they had found in their cohort. Now briefly discuss about the clinical presentation of thoracic OPLL. So it occurs in approximately 30% of patients who have thoracic or lumbar involvement, and they typically don't have concomitant cervical involvement, which is interesting. Women are more commonly affected, and then the classic sign and symptoms of thoracic OPLL, which you can see on this sagittal image and axial image here, are symptoms of myelopathy again. So paraparesis, the lower extremities, spasticity, gait disturbance. Those are some of the most commonly frequented things you'll see should that a person like that present to your clinic. This was an interesting study. This was published in Journal of Neurosurgery in March of this year. This is looking at the distinct progression patterns of OPLL in the thoracic spine versus the cervical spine. So they looked at 123 patients with symptomatic OPLL, and they scanned them at intervals of 3 years, and then divided them into a cervical OPLL group and a thoracic OPLL group. And what they found was that patients in the thoracic group had about a 7% increase in their progression of disease as compared to the cervical cohort. They found that young age was a common risk factor for both groups. And in the case of thoracic OPLL, they found that a high BMI, severe disease initially, and male gender were put you at increased risk of progressing in terms of the thoracic OPLL on CT scan, which I thought was interesting. While we talked about the clinical presentation, I think it's also important to be aware of the fact that these patients may run the risk of developing spinal cord injury, even from minor sustained trauma. So while you may have the large preponderance of patients presenting with these signs and symptoms of gait instability or numbness and paresthesias in their hands or legs, patients also to present with spinal cord injury, and this can be due to just minor trauma. This was an interesting study, albeit done quite a while ago in 1995, but it was 118 patients treated in clinic from 1976 to 1992. And 27 of those 118 patients sustained minor trauma to the cervical spine. And of those 27, 13 developed myelopathy, and then 7 showed deterioration of their pre-existing myelopathy. So 20 to 27 patients with just minor trauma had developed severe symptoms. And then similarly in 2012, Wu et al., they looked at, this is published in the Journal of Neurotrauma, 265 patients hospitalized for OPLL. These are patients who actually were refusing surgery. They then followed these patients long-term and found those patients who were symptomatic but refused to undergo surgery later on were 3 times higher of developing cervical spinal cord injury on interval follow-up. So now I just want to delve into the diagnostic imaging. So in terms of the workup of these patients for surgical planning, these are all the imaging studies that can be helpful, obviously. So plain cervical radiographs, dynamic films also can be very important, as well as CT and MRI can help elucidate the severity of the underlying disease. This is a nice image on the far left. This is a static cervical radiograph. You can actually see the OPLL starting from the C3 body, extending down to C4, and even all the way up to the bottom of the C2 vertebral body. You can then see that this continuous OPLL on CT scan. CT can always be very helpful to delineate the extent of the ossification. Then obviously the MRI can then show you the extent of any cord edema or T2 flare signal change within the cord. Dynamic films can also be extremely helpful. Here's a great example of a patient who has OPLL from C2 to C4, and after to C almost to C5 actually, and after that OPLL segment stops, you can see there's significant dynamic movement on flexion versus extension. This disc space actually flares open, and this can be helpful in determining the rigidity of any kyphosis the patient may also have, or if deformity correction is also considered, and is important to be aware of as well. And then obviously CT is a very sensitive method for imaging OPLL. You can really understand the details and margins of the morphology of the ossified mass. And these are the 4 different subtypes that I want to discuss of OPLL. So one is focal, meaning you have like focal ossification at the posterior margin of the vertebral body. This is the segmental subtype, where you see ossification behind each vertebral body. This is the continuous. This is stick-like ossification. So this can span multiple vertebral bodies, more than two, excuse me. And then this is mixed OPLL, where you have both combined segmental and continuous OPLL in the same patient. So now I want to discuss the natural history. So a few researchers have actually evaluated the progression of OPLL, over the course of a patient's lifespan. However, there have been a few helpful studies. In 1997, Takatomi, he looked at 112 patients who were followed with conservative treatment over 5 years to see, if radiographically anything changed in terms of the significance in terms of the size of the ossification. And they found that both the length and thickness increased, incrementally over that 5-year follow-up period, with the length increasing up by 24% and the thickness by 13%. But it's important to weigh those numbers clinically in a patient and see how that actually impacts the patient in terms of their myelopathic symptoms. So Matsuga looked at 450 patients, and this was over 17 years, and he found that 17% of patients who were non-myelopathic, so largely asymptomatic, actually became myelopathic during follow-up during that time. And patients with significant myelopathy initially became wheelchair-bound almost 90% of the time, which is quite significant without surgery versus 17% with surgery. I'm going to show you that, especially with patients who come to you initially with any sort of symptoms of myelopathy, if you don't operate on them, you are potentially, risking a life for them where they're essentially, non-ambulatory. So now just to briefly discuss, conservative treatment, some surgeons may, if a patient's truly completely asymptomatic, and they have no symptoms of myelopathy on the Japanese Orthopedic Association score, which is often used, which I include in this table here, or if they truly have a neuroclassification of 0. I included that here, in this bottom figure. Some surgeons may opt to manage them conservatively. Things that one can try are things like NSAIDs or muscle relaxers, and obviously avoidance of any extreme activities. However, this is not going to work great, obviously, for any symptomatic patients. But again, it's pivotal to actually to follow these patients clinically if you're going to do that with either systematic follow-up with documentation of the clinical status with their JOA score here, or a neuroclassification, so you can follow them clinically, and if their symptoms do develop, to offer surgery. This was also something interesting that I found. This is a survey of spine surgeons in 16 Asian countries that were polled regarding, specifically cervical myelopathy. And it was interesting, only 5% said they would operate on asymptomatic patients, and 18% would offer surgery to patients with mild symptoms. So a JOA score of greater than 15, which I thought was interesting. Obviously, different parts of the world have different practice models. But if you're going to be in this group of surgeons, it's important again to follow those patients closely. So now finally, surgical treatment, something that I found to be the most interesting that I want to delve into right now. So, excuse me one second. In terms of considerations, the primary surgical indication is progressive myelopathy, obviously. So this is typically manifested, for the juniors by considerable numbness, weakness in the upper and lower extremities. They've lost their dexterity, spastic gait, and in terms of decisions on surgical treatment, like we said, while preventative surgery for OPLL in patients without symptoms, can be controversial because of the inherent risk. It's important to know which patients are most at risk of developing spinal cord injury. This was an interesting publication done in 2012. They specifically looked at risk factors for acute spinal cord injury in OPLL, and they found that patients with mixed or segmental OPLL were at greatest risk of spinal cord injury, which I thought was interesting. And I want to include this figure that talks about the mechanism of injury. So think about a patient with mixed OPLL. They have this long continuous segment that is essentially immobile. You then have this segment of just segmental OPL just behind vertebral body, but the area above and below that vertebral body, there is no ossification, so that area is mobile. So if when a patient were to hyperextend their neck, that area that has much more excessive motion than the areas above or below, those lamina will buckle when the patient hyperextends, and that ossified mass is going to compress the cord. So, one way to potentially think about, surgical indications for patients is specifically to look at their subtypes of OPLL. They have like mixed or segmental subtype where they have excessive motion in between the vertebral bodies themselves. They're much higher risk of developing spinal cord injury in this study. And surgery may be more warranted for those patients. I'm not saying whether that's right or wrong, but again, something interesting to think about. In terms of the two basic approaches for OPLL, one is either direct removal of the ossified mass, and two, either posterior decompression using laminoplasty or laminectomy to expand the canal posteriorly to allow for a more indirect decompression, where the hoping that the cord will migrate dorsally. So as of this writing, no surgical approach is standardized, and this thought process of what approach to use continues to evolve. In terms of the surgical treatment options posteriorly, things that have been offered in the past include laminectomy. However, this is I would say lost favor as of most late. Laminectomy with fusion, laminoplasty. So and the different types of laminoplasty like open door, French door, and then finally standalone fusion. This has been something that's been promoted by Atul Goel, who's a surgeon in India, that I'll briefly touch on as a possible treatment modality for these patients. And the advantages are obvious. The anatomy is more familiar. It can be more extensile, and patients you can avoid the dysphagia and dysphonia that you typically associate with an anterior approach. And obviously, if you offer laminoplasty, it does not require any fusion, and obviously a lower rate of CSF leak. The disadvantages are pretty obvious, I think. You have to rely on indirect decompression, especially if the compression is anterior. In these cases, patients can develop postoperative kyphosis. There's a high rate of C5 palsy, and overall poor results for patients with severe symptoms because, again, you're relying on that indirect decompression. These are just as an example of laminoplasty type procedures that you can perform for these patients, whether again they be the open door or French door technique, and these are the plates that can be used as well. In terms of posterior spinal fixation alone, this is definitely a controversial topic. So Atul Gul published this in 2020. He looked at 52 patients who he treated exclusively with spinal fixation without any form of bone or soft tissue decompression whatsoever. You can actually see his postoperative CT scan and the reconstruction here. So he essentially relied on facet fixation for both atlantoaxial and subaxial spine. And he documented the analysis of video recordings before and after surgery in these patients. And he had the patients provide self-assessments, which were included in the analysis of the outcome. And he published that of the 14 patients who were wheelchair bound before surgery, 12 walked independently on follow-up assessment at 6 months. And his argument is that OPLL, this forms and progresses over time because of micromotion. And the best way to get rid of micromotion is to fuse it. And he thinks this is, a method to treat these patients, which is interesting. Again, don't want to say whether this is right or wrong, but just wanted to put that out there because I thought it was, an interesting way to go about treating these patients. In terms of anterior approaches, the two most commonly used approaches are ACDF and cervical corpectomy. And a more recent approach that came out of Shanghai, China, is this anterior controlled anti-displacement infusion technique, which has been described as of late, which I'll delve in more as the talk progresses. The advantages of an anterior approach are obviously it allows for direct removal of the OPLL. You have, elimination of any dynamic pathology. It allows for potential kyphosis correction and obviously allows for better neurologic results postoperatively because you are resecting the ventral ossified mass directly and allowing for direct decompression of the spinal cord. The disadvantages are, obviously dysphagia and dysphonia, CSF leak, especially if the dura is ossified as well, which I'll delve into. Obviously, there's a risk of subsidence and graft displacement, especially if you're doing, a multi-level corpectomy and not backing it up posteriorly, and also loss of range of motion. So, which is better, anterior or posterior? This is a age-old discussion that continues on to this day. This is the most recent meta-analysis that was published within the past year. This group looked at 30 studies, over 2,000 patients, specifically looking at their JOA scores to see how they improve postoperatively clinically, and looking at their levels of cervical lordosis, and they found that in patients who underwent a corpectomy, they found it to be superior to laminoplasty and laminectomy infusion, which intuitively, makes sense because again, you're decompressing the cord directly. However, there were obviously higher incidence of overall complications with a corpectomy procedure as compared to, laminoplasties, let's say. So now I suppose we want to discuss this procedure that again was first published in 2016 and is used sparingly throughout the world, mainly in East Asia. And this is this anterior controlled anti-displacement infusion procedure. So it was initially developed to address continuous OPLL that went up multiple levels, 3 or more of continuous OPLL. And it was developed to mainly avoid the risk of durotomy that these surgeons were encountering. It involves the resection of the anterior body, which you can see in this image here, and then lateral osteotomies, and then you have anterior displacement of the vertebra fusion. And it showed encouraging preliminary results in their first publication. This is an image from their first publication in 2017. They looked at 15 patients with cervical neuropathy. This is showing the osteotomy clips they perform at each vertebral joint. They configured the drilling. They put a temporary plate when they're doing the cuts as they're destabilizing the spine, obviously, and then they do the other osteotomy cut on the other side. And they followed these patients both radiographically and clinically, and they found that their mean JOA score actually increased from 9 to 14 at 6 months follow-up. And they got postoperative CT and MRI which showed, excellent decompression of the cord. This is just a case example that they published. This is like pre-op CT, post-op CT. This is showing the osteotomy cuts on the coronal CT scan. And then this is the pre and post-operative MRI, where you can see they use this kind of bridge cane, analogy, where after you do osteotomy cuts, you essentially bring this large ossified mass up towards the anterior cervical plate with screws, lifting off the ventral ossified mass off of the cord. The same bridge and crane would work. This is just another step-by-step diagram showing the procedure itself. I don't want to belabor the point, but the whole goal essentially is to bring up this whole ventral ossified mass up to the anterior cervical plates after you've done your decompression, taken down the PLL above and below, and done your osteotomy cuts. This is an interesting study. This is published in Journal of Neurosurgery, and this year, January 2022. This is looking at the biomechanical durability. Obviously, you're destabilizing the spine quite a bit when doing this procedure, and they found that that the ACAF procedure was actually similar biomechanically to that of an ACDF, and significantly better than a corpectomy, which makes sense. You're not drilling the entire vertebral body off, so it's important to know that this ACAF procedure has actually better durability, at least in cadaveric studies. In terms of randomized controlled trials of clinical studies looking at this technique, this was an interesting study published in 2020 comparing the ACAF procedure to laminoplasty. And the authors found that at 1 year follow-up, the JOA score and recovery rate were actually significantly higher in the ACAF group than those in the laminoplasty group. Their neurological recovery had improved, and it was specifically for patients who had a large ventral ossified mass that took over greater than 60% of the spinal canal, and in patients who were described as K-line negative, which I'll discuss shortly. This same group was then followed at 2 years, and again, they found that the ACAF group, this anterior controllable anti-displacement procedure, those patients did superior to the laminoplasty group. You can see this table where they compare their preoperative and last follow-up JOA scores. They jumped from 8.5 to 14.6 in the ACAF group versus 9 and 12.8 in the laminoplasty group. They noticed the p-value was actually significant, less than 0.05. And in terms of their complications, there was 0 postoperative hematoma. CSF leakage was similar between the groups, and there were no incidences of pseudoarthrosis, spinal cord injury, or any implant complications. So again, I bring this up just to talk about novel strategies that are now being used, especially within the past just 3, 4, 5 years, that are being offered to patients with this disease. Now, I want to briefly delve into other factors to consider in OPLL treatment. One is obviously the clinical factors that you should be keeping in mind when thinking about a surgical strategy. But other important things that have been recently published on within the past few years are patients with dural ossification, their canal occupying ratio, so how much of the ventral ossified mass takes up the canal and how that can change your surgical management, whether the T1 slope affects your surgical decision making, and finally, the K-line and the significance and what this is. So first, I want to talk about dural ossification. So dural ossification can be detected in 10% of patients with OPLL. And this is something I was unaware of prior to investigating this topic more in depth. There are 3 basic patterns that are described of dural ossification. So you can have isolated dural ossification, which is actually separate from the OPLL and is usually small and localized, seen in this first image on the left. You can then have a double layer dural ossification in which you have a visible plane between the OPLL and the dural component. And then finally, you can have this mass type or en bloc dural ossification, and you see no delineation between the OPLL and the dura. And these are the patients who have the highest rates of CSF leak. This is actually the type of dural ossification a patient that I helped operate on had that developed a CSF leak. And Now looking back, it's obvious as to why there's really no delineation between the dura itself and the OPLL mass. This is just a surgical technique, kind of looking at the approach you could possibly use for the patient for dural ossification. You essentially will drill down carefully the OPLL, and if you can find any sort of boundary between the OPLL and this dural ossification, you can use a blunt nerve hook or another technique to try to peel that OPLL off, and then you can see the authors left this dural ossification on the spinal cord and then place a corpectomy cage. Some, however, have argued that if a patient does have a dural ossification, specifically this type 3, it may be better to go posteriorly just to avoid the high rates of CSF leak that are associated with it. Other considerations in OPLL treatment, one is this idea of the canal occupying ratio. So then you essentially take a percentage of how much of the ventral ossified mass is taking control of the spinal canal, and looking at this specifically can help you delineate whether you should go from an anterior posterior approach. Through my literature review, I found that greater than 50% of canal occupying ratio favors an anterior approach, and this is because you can directly decompress the spinal canal, and patients, in terms of their neurological recovery, their JOA scores are more improved postoperatively if you go from an anterior approach. Again, in those patients who have a large ventral ossified mass taking up more than half of the canal. Another subject that's been researched on is the notion of a T1 slope. We always talk about sagittal alignment, but it's important to think about cervical lordosis as well, and the alignment in the cervical spine. So the T1 slope is the angle between the superior end plane of T1 and a horizontal plane. And it's been recently examined as a means to kind of define normal cervical lordosis. And the greater the T1 slope, the more cervical lordosis a patient needs in order to be classified as having a normal degree of curvature. And this notion of a T1 slope has been looked at specifically in patients who undergo laminoplasty for OPLL. It's been found that patients with a higher pre-op T1 slope tend to have a greater loss of lordosis after laminoplasty. This was an interesting study published in 2018. They observed that patients undergoing laminoplasty for OPLL, those with T1 slope greater than the median, so greater than 30 degrees in this cohort, had greater postoperative loss of lordosis. They only followed these patients for 12 months, but they said that this loss of cervical lordosis, they found not to be associated with poor neurological outcomes. However, I wonder if you follow these patients over 10 years, if their neurological outcomes change at all, and whether or not we should be paying more attention to the T1 slope when offering an anterior posterior surgery. Another recent study of T1 slope, this was published in 2017 in the Journal Neurosurgery Spine. They found that older age and a high T1 slope to be risk factors for loss of cervical range of motion, so loss of lordosis and interlaminar fusion. But again, they did not. They said this did not affect neurological outcome. So again, this is another thing to be aware of. Whether how helpful this may be in the future is unclear. But we typically think about patients with preserved cervical lordosis as good candidates for laminoplasty because it allows for dorsal migration of the spinal cord when their lordosis is preserved. But bringing up this question of T1 slope may change that. So finally, the K line. So this was first described in 2008. This was described as a line that's drawn on a lateral cervical radiograph. So you extend a line from the midpoint of the canal at C2 down to the midpoint at C7. And you're essentially looking at whether this ventral ossified mass stays anterior to this line. So if it stays anterior to the line, patient is called K-line positive. If the ventral ossified mass extends posterior to the line, it's identified as K-line negative. And in essence, the line helps account for like the combined effect of ventral ossification and the patient's cervical alignment. You can see this patient who's K-line positive, the ventral ossified mass is anterior to the line and they have good cervical lordosis. So this would be potentially a patient that could be offered a laminoplasty because their alignment is well preserved and the ventral ossified mass doesn't take up most of the canal. And this patient with K-line negative disease, they have complete loss of lordosis, the neck is kyphotic, and the ventral ossified mass takes up a larger portion of the canal. So in terms of surgical approach, what ramification does this have? So in the initial report in 2008, where this K-line was first brought up, they found that patients who underwent posterior decompression and were K-line positive, the 19 patients who underwent surgery posteriorly had recovery rates of 66%. However, patients who were K-line negative, their recovery rate was only 13.9%, again, going posteriorly, which goes to show you, how important it is to look at your radiograph. I'm not saying you should go and draw a K-line for every patient with OPLL, but looking at their cervical lordosis, how much of the ossified mass takes up the canal, putting that all together can really help you decide whether to go anterior or posteriorly and what's going to be the best option for that patient in terms of their neurological recovery. You can see, their JOA scores before and after surgery. In the K-line positive group, it went from 8.9 to almost 14. In the K-line negative group, it went from 7.3 to 8.9, which is a marginal improvement, if any. A patient with just a 1 point improvement would probably say in clinic that surgery didn't help them at all. This whole K-line idea has been expanded. So more recently, there have been several publications that have come out over the past 3 years, 4 years that have expanded the concept to include a dynamic component to the K-line. So in this case, you have the patients perform dynamic X-rays, have them flex and extend. And when you have them flex, you measure the K-line again, measure where that ossified mass is. And numerous now publications have come out saying that patients with a flexion K-line negative ossified OPLL, they do significantly worse when a posterior cervical laminoplasty is performed. So again, this kind of brings up the concept of getting dynamic cervical radiographs, again, to better understand the patient's alignment prior to surgery. And whether the flexion K-line can be helpful to you in practice, I can't say for certain, but I think it's important to bring up and important to keep in mind when you're seeing these patients in clinic. And then now finally, what about K-line positive patients? Intuitively, if they have good lordosis and they have good alignment, the ventral ossified mass doesn't take up most of the canal. Going from an anterior approach from a posterior approach intuitively should still help these patients. And that's what, this paper documented. This was published in Journal of Neurosurgery Spine in January. They found that clinical outcomes for both the anterior and laminoplasty group were essentially equivalent. They did not detect any significant difference in clinical outcomes. They also documented the complication rates between the anterior and posterior approach. Obviously, this goes to show you, when you go anteriorly, you do run the risk of more complications, dural tears, CSF leaks, implant dislodgements. Laminoplasty is a true and tried technique. And with someone who's comfortable with that technique is a great option, especially if you don't want to have a lot of complications with your patients, and it can have great outcomes, as this publication clearly identified. And again, this is done January of this year in the Journal of Neurosurgery Spine. So now kind of bringing everything together, these are all the considerations for kind of selecting a surgical approach in a patient with OPLL. So this is kind of taking everything into account. How many levels their OPLL goes down? Is it multi-level? Is it segmental? Is it continuous? What their K-line looks like, and how that kind of steers you going from doing an anterior corpectomy, doing a laminoplasty, posterior decompression, and keeping things in mind like whether the patient is a smoker or not. Obviously, if the patient's a smoker, you're less likely or excited to do a fusion on laminoplasty and be a great option for that patient. So I think it's really important to tailor each surgical approach to each specific patient, and taking all these radiographic parameters and keeping them in mind when offering surgery. So hopefully we accomplish all our goals today. We went over the history, the epidemiology, the pathophys and histopathology of this disease, the clinical presentation and the diagnostic imaging. And finally, we briefly touched on the natural history of this disease and all the surgical management and, the nuances that I hope were new and exciting for you all, because definitely things that I didn't really know about. And I'm now appreciative of the fact that I know a little bit more about this disease and how to manage it surgically. So, in conclusion, we need more data, obviously. There are, very few like randomized controlled trials comparing, anterior versus posterior surgery. There is a new study, a randomized control study in Japan that's coming out, which hopefully should be published in the next few years. A randomized control study comparing anterior versus posterior, specifically that ACAF procedure that I discussed versus laminectomy, infusion, and laminoplasty. So, more data can help us delineate what surgical techniques are best for our patients. And I think most importantly, we've got to individualize care for each of these patients and hopefully come up with a great algorithm to help as many people as possible. So with that, thank you so much for your attention. And if you have any questions, do not hesitate to ask. Thank you.
Hey, Arya, great job and a very nice overview. I think I agree basically with everything that you said. And the one thing that I don't think that you addressed as much is this issue of laminoplasty versus laminectomy infusion. You did have it on that table.
Oh, right. Yeah.
Whether there is progression of disease in laminoplasty only, which I think there's some data to suggest that there is. And so maybe laminoplasty isn't the best treatment for OPLL.
Right. Yeah. Sorry for not including that. I did I come across that during my literature review, like looking at patients over 10 years. And this kind of goes into the concept that Atul Goel talked about in his paper, where he just fixated the spine, didn't do any decompression, just did a spinal fixation for like 52 patients that he published in the World Neurosurgery. This whole concept of micromotion leading to progression of the disease, and like you said, obviously with laminoplasty, you're not fusing the spine, so that micromotion persists, and that ossified mass they found to get larger and larger over the long term. So yeah, you're absolutely right, especially in a young patient who has 30 years left to live. A laminoplasty may not be the best option because that ventral ossified mass may grow by the time they're 70 and cause symptoms again. Obviously, doing a laminectomy infusion eliminates that micromotion, and they found that progression of the disease is halted on radiographically 10 years follow-up. But yeah, no, thanks for bringing that up. I forgot to include that in my literature review. But yeah, that's definitely something I came across, which was interesting.
And the other thing I was going to say, again, great job, is that with going anteriorly, you emphasize the CSF leak, which of course is never good and can be very difficult to manage. And they can present with, CSF collections in the front of their neck. But, the other thing that's not sort of brought out in the one paper you showed in the JNS is that, there is a defined risk of spinal cord injury from anterior approach. And definitely, I would say it's higher anteriorly than posteriorly. It's uncommon, I would say, but you only need to have one case to really affect your thinking. So I think you're forced into a corpectomy approach if it's mostly ventral and if they're kyphotic. But if you don't have those, then certainly posterior is a lot easier on the surgeon's GI tract.
Right.
That was the only other thing I was going to comment on.
No, yeah, thanks. That's another great point. Keep putting a kerosene in when you have a canal that's 1 to 2 millimeters in diameter due to that ventral ossified mass can be harrowing. So yeah, absolutely.
On the contrary, Aria, good job. I really appreciate you putting all this together. It's nice that you've introduced the notion that OPLL or at least around the world, is being looked at as an anterior disease, and people are addressing it through the anterior approach. Traditionally, anytime you talk about OPLL, people would refer to the original Japanese data and say, oh, OPLL, just posterior decompression, that's it. It's already been proven. But now you can see, especially with this ACAP procedure, which is pretty neat. And I think if you want, as a chief, we can talk about it. We have everything already in place at Jackson to do, to perform it, using the navigated instruments.
Right.
And you talk about passing the Kerrison, but I hope you understand, passing the Kerrison right where OPLL is should not be happening, right? A lot of lateral gutters are open, and that's what ACAP investigates. So really appreciate you putting this together. Thank you.
Yeah, absolutely. Thanks.
Hey, Arya. That was awesome. It's a really interesting topic, obviously, because you're always perseverating. I personally am about, anterior, posterior, even in regular degenerative cases.
Right.
And it is kind of surprising that this, it's like motion preserver in this disease where you think it's due to micromotion. That was going to be my question, but you've already talked about it. But can you just go over the T1 slope one more time? Because I think people have applied that also to degenerative pathology, right?
Right. Yeah. So like the argument that some people were making was that when you offer a motion preserving surgery like laminoplasty and someone with a high T1 slope, if they have a high T1 slope, they require a lot of cervical lordosis to begin with to maintain kind of a normal alignment. And when you're doing a laminoplasty, you're going to lose some of that lordosis, despite, preserving as much of the posterior tension band that you can, or the ligamentous structures. But those authors were saying that, while that you lose a significant, much more cervical lordosis than you may think, especially in patients with high T1 slope, and that they actually lose some significant amount of like range of motion in their neck. But they did say that over like on 1 year follow-up, they don't have any deterioration in their neurological outcome. But I guess what I was trying to get at was maybe at 10 years, maybe not at 1 year, but maybe at 10 years, patients with high T1 slope who undergo laminoplasty, they can start losing lordosis more and more year after year. That can potentially lead to that the spinal cord losing that its dorsal migration, and then patients becoming symptomatic in the long run. That hasn't been shown because the studies I found only had like 12 months follow-up, but that's the only thing I was trying to get at, that patients with a high T1 slope, a laminoplasty, although may not be the best option. But again, it's difficult. It's still, despite everything I've read, I still think it's difficult to come up with a great algorithm. But I just wanted to show out these other radiographic parameters that we can use to try to make the decision process a little easier.
I wouldn't use that point as an excuse to instrument everybody.
Right.
With T1 slope and just offer fusion right off the bat. Right. Especially like you said, neurologically or clinically, there was no sequelae. This is all radiographic, which makes sense if your posterior lordosis is maintained by the cervical muscles, and you can also denervate them probably if you expose too much. So the 12 months follow-up is very short from that point of view. I think it's still recovering.
Right. Definitely. Okay, awesome. Well, if there aren't any more questions, hope you guys have a great rest of your day, and thank you so much for your attention.